Welcome back to another episode of More Than Milestones. I am joined today with a dear friend of mine who I was lucky enough to connect with in this space years ago, and we have just she's wonderful. This is Dr. Anjuli. She is a board-certified pediatrician at CHOP, which is the Children's Hospital of Philadelphia, and she's the face behind Resilient Rascals, where she shares her incredible knowledge and expertise with the world, and we love her for it. Thank you so much for being here. Tell us quickly a little bit about you. Where can people find you? Tell us.
Oh, Case, I'm so happy to be here with you. I feel like we've, just gotten to develop such a beautiful friendship over the last few years,
Mhm.
and it's nice to see you doing this in this new journey. So my name is as Anjuli Gans. I work as an attending at the Children's Hospital of Philadelphia as a pediatrician there. I do research, I teach, and I really love to sharing education on health and development, first aid, anything that kind of is early childhood for parents. And so the best place to find me is either my website, resilientrascals.com, or on Instagram at resilientrascals.
Amazing. And
Sure.
today, winter is upon us, or many of
Mhm.
us. And so I thought that it would maybe be helpful to just talk about navigating some of the big common winter illnesses with both newborns and little ones, because I know sick season is anxiety inducing for so many of us. And I think it might be helpful to start with expecting a winter baby for parents, because having a newborn during sick season is obviously even more terrifying, especially if there's
Yes.
older siblings that are around. I'm sure that you have lots of advice about what parents that are expecting in this winter season can either implement or think about, or all of that. So let's start there.
I had two winter babies. I don't know when your babies were born. I can't remember.
I have a spring, a winter, and a summer. So
Yes, you
all
got them all right. Yes. So I remember just thinking about family gatherings and all of those things. So I think about it from the perspective of having gone through it as a mother, but also as a pediatrician who sees all these new babies right now, and it's so exciting and fun. But it's also, I know, anxiety producing for parents, especially over the last few years. I think just our health anxiety in general has been a lot higher than in the past. So when I'm seeing a baby in clinic or when I'm talking to friends who are having new babies, I always say there are so many things you can do. And then there are some things that are out of your control, and that's okay as long as you know kind of what the next steps are, right? So, in terms of things that every parent can do, one is I always have parents talk about RSV protection. So we now have a vaccine that moms can get during pregnancy, and there is a shot for babies who are up to 8 months or who are older than that if they have chronic medical conditions. And those are incredibly protective for serious RSV hospitalizations. And RSV and bronchiolitis, it's horrible. If you have had a little one go through it, it can be really scary. It can have really serious consequences. So that's one of the first big things they can do. And
Mhm.
then as far as having older siblings at home or exposure to other people, I always say it's always good to practice with your older siblings because it's a hard enough transition with your babies. But to kind of practice giving them special spots on the baby that they can kiss, to give them maybe to practice with a routine for when they come home from school or from childcare where they take off their clothes, they quick wash their hands. I feel like all kids kind of practice that now in school or childcare settings. So that's something that just reiterating it at home can really help with because just keeping the germ load as low as you can going from outside to inside your home can really help. And then kind of thinking about how you want to manage family gatherings. And there's no one right answer. I know parents have a lot of different views on how they want to see people, if they want to see people, if they don't. There's lots of ways to do it. But I like to kind of tell people to start thinking about that beforehand so that when they're in the moment and like with a new baby and feeling really emotional and having a lot of people place demands on you, they're not dealing with it right in that moment.
Yeah, I love that. I think that's super helpful advice, and not necessarily something that we're often thinking about until it happens, and then you're like, "Wait, am I going to Thanksgiving? Am I going to
Yes, like
Christmas?"
what's happening at Christmas and yeah. So, and there's no one right answer. We kind of have said traditionally, obviously, a fever in a baby who's younger than 3 months old, or babies who have other chronic medical conditions or have a different vaccination status are always things that we want to elevate to a higher level of care. But also, there are lots of ways to mitigate that. And it's also important for some parents that they have company, that they see family, that they're not alone in that process too. And so there are different ways to weigh that out.
Yeah.
There's a lot of really interesting data actually on we kind of give this education of like, oh, no visitors for 2 months or no visitors until you get your vaccines or other things. But if you have an older sibling at home or multiple older siblings at home, right, they're already exposed to a high germ load. And so there
Oh.
is some interesting data that might be the source of exposure more than other guests as well. And so,
Hmm.
it's different for every family, kind of what matters for them and what values they have and who they want in their lives at that moment.
Yeah, totally. That makes sense. And so that, just to reiterate that piece, so what should a newborn parent be looking
Yeah.
for to say like, okay, this we have to go in, or, kind of that delineation?
So the one thing that I always want parents to know is how to take a temperature in their newborn. Okay, so they can take a rectal temperature or they can do it under the armpit. There's some data that you could take it across the forehead, but really just rectal or under the armpit is probably the easiest thing to do at home. And anything above 100.4, you don't have to add or subtract, just anything above 100.4 in either of those should be a call to your care team for immediate evaluation. Okay. And that's just because, their immune systems are still so immature, they're still developing, that they can be at risk for more serious bacterial infections at that time. And then knowing what to look for in terms of how your baby's breathing. And I know we'll talk about that a little bit more.
Mm.
What is normal and what's not normal? Those two things can tell you the most if you have a young baby or a newborn, for when to seek care.
Okay. And can we just circle back? Is that new that you don't add or subtract depending on where? Because I saw something else about that floating
Yeah.
around and I was like, whoa, that's new information to me. Is
Yeah.
that?
Yeah, you really honestly, it's a great question because in the old days, people used to say, you take one off if you're doing it this way, or if it's a ear, it's
Yeah.
higher. There probably is some variation, right? Like we know when you take temperatures, it's always all over the place and you never really
Mm.
know exactly where it is. So, a rectal temperature is the most accurate temperature for babies until they're 3 years old, really. But an
Wow.
axillary or an under armpit temperature is fine as well to estimate. Um, the reason we don't tell you to add or subtract is people get really focused on the adding and subtracting. And if it's generally around that number, like 100.4 really for that age. If it's under your armpit and it's 100.2, we want to check it regardless. So it's not that it's new, it's just that really we don't want you to change it up too much. We just want to get one number. And then when we trend it, we use that. Or if you
Okay.
come in, we probably will check a rectal or a more accurate way. It's also less math. Nobody needs the math. You just
Yeah.
number. It's so hard to think through when you're dealing with it, right?
Yeah, totally.
Sort
Let's
of.
let's start with stomach bug then. So we
Okay.
all we all know the dreaded stomach bug, and you know that when
It's
it hits your
horrible.
house, it's like it's about to rip through everybody, right? I know you have like a step-by-step breakdown of what to do if you're dealing with the stomach
Yeah,
bug in your family, but
yeah,
starting kind of from the top, like what do parents do when the stomach bug hits? What would be your like, here is the sequence of events that we need to be thinking about?
yeah. It's a great question. I think like step by step, number one is just to take a breath because we all feel that same anxiety of like the second you think it's coming, all you're thinking about is everybody's going to get it and this is going to be horrible.
Mhm. Yep.
Which is, I know how I feel. So I say that understanding that, like, all you're thinking about is like, it's going to be such a huge thing. It's going to knock us all out. It's going to be miserable to clean up and deal with. So, number one is just take a deep breath. Number two is I always say to kind of like lay out your space. So, if you can designate one bathroom in your house that can sort of be isolated to people that are sick. If you can have a little station for wherever you want whoever is sick to be sitting, like cover it with a set of sheets or a waterproof mattress protector or whatever works in your house, just set up a station and then have barf bags ready, have bowls, whatever you use to kind of get supplies together. I keep it all in a caddy, and I always say, just get your station set up. And then I would make sure that you have ahead of time or as soon as you can the right kind of rehydration stuff at home because you know how it goes. Like your kids are sick, and then suddenly you're like, ordering things to come to your house and you feel like you have
Yeah.
to race to the pharmacy or just order it. And so if you have everything ready, you can be fine. And that's, that can be something like an oral rehydration solution that the WHO recommends, or Pedialyte or Pedialyte popsicles, breast milk formula, just making sure you have what you need for rehydration because that's all you really need for the first couple days of the stomach bug.
Yeah.
Um, and then I don't know, Case, I don't know how you manage this in your family, but I always say figuring out the next couple days of childcare, of work, of what have you, because if you can figure that out and it's going to be a couple days early, you
Mhm.
can just kind of focus on your kids and caring for them. Does that make
Yeah.
sense? So
Yeah,
that's what I
absolutely.
say to start with. And then, as far as stomach bugs, I think in the first day or two of them, it's often not about intervening so much. It's just kind of helping your kids feel comfortable, letting them rest when they can, and then letting them get hydrated however you can do it slowly and kind of going. And then after a couple days, once they feel a little better, then you can really focus on helping them to get their nutrition back and things like that.
Yeah. And you have tips on that as well, right? Like introducing
Yes.
something, waiting.
Exactly. Yeah. So there's actually like a pretty good formula that we use in pediatrics, which is if your baby is throwing up or your child is vomiting, give them a minute, let them rest for an hour or two. They don't have to start trying to rehydrate immediately. But if you wait for a few hours and then you want to start for infants, it's a little different than toddlers and it's a little different for younger kids. But you basically want to do something like 5 milliliters to 10 or 15 milliliters. So 5 milliliters for infants, 10 for toddlers, 15 milliliters. That's, tiny, tiny amounts like 1 teaspoon, 2 teaspoons, and 3 teaspoons every 5 to 10 minutes to see if they're
Huh.
able to tolerate anything. And honestly, if you came into the emergency room, that's how we test if a child is able to go home or if they're going to be admitted. We will slowly rehydrate them. We'll give them tiny little volumes or sips of a popsicle that equal 5 milliliters, 10 milliliters, or 15 every 5 to 10 minutes to see if they're able to tolerate that at home. And so if you do that for 2 to 4 hours, you're kind of getting their basic hydration needs met, number one. And number two, if you have to take them in, if they can't tolerate that, that would be a sign to say, you know what, we're really not keeping anything down. We probably need to go to an urgent care or to the emergency room. Or they kept that down. That's great. Let's keep going and kind of increase from there.
Yeah. And now is there like a timeline of, okay, if they've been vomiting for 24 hours straight and they're not able to keep that stuff down, is that the point, or is it less than that? Is it 12 hours of active, say, vomiting and then they can't keep that down?
Yeah, that's a good question. So usually you want to give them like I was saying 24 to 48 hours where, the first day they may just really be throwing up and they may not
Okay.
feel like eating anymore, but after that time if you start to try to rehydrate them and they're really not able to keep anything down and or if you notice their urine output is decreasing so they're not peeing as much or if they just seem really out of it to you. They don't seem themselves beyond what you would expect from just being ill. Those would be
Uh,
signs to go in for, yeah.
okay. I love it. Makes so much sense. And don't you have like an emergency guide? Like these are the things that you should have at home? You
Yes,
do,
I
right?
do.
On your
So in
website.
so I have a set of guides on my website. And they go through all the things that you'll go through in the first like 5 years of your kids' lives. Just every illness, every kind of stomach bug, respiratory thing, fevers, stuff like that. And it walks you through step by step and then also gives you a list of sort of what to have at home. And I try to do that with every post I do in social media as well, just so that you feel like you have what you need at home and you're not frantically looking for it in the moment to be prepared. Yes.
Yeah, totally.
Yeah.
And we will link that in the episode notes too because it is truly like
Sure. Yes.
invaluable. And you
Yeah.
don't know what you need until you need it. And then you're like, well, crap, now I got a sick kid or a bunch of sick kids and I have nothing.
Yes, like, I know we love those vomit bags, you and I, but they are literally, like, lifesavers. Like, since the day I was pregnant, I've had them in every car, in every, like, room
Yes.
at our house, and those are things I never would have known of before, but now I look back and I think, "My gosh, I can't imagine getting through, like, a stomach bug without them or
Yeah.
car sickness or anything." So I think it's those little things. I always say, like, the step-by-step things in my guides or that I put out on social media are all based in like the latest pediatric evidence-based guidelines. It's all things that you will see at a pediatric ER. And it's really based in that just to help parents know, like you were asking, exactly when to go in, exactly what they can do at home. And I think that having the right equipment at home can really help with caring for your kids. So hopefully it's
Yeah.
helpful to families.
Oh,
Yeah.
no, it definitely is. I have to say, as we pivot to talking about croup and breathing, which
Mhm.
I don't know about anybody else, I fear croup more than I fear the stomach bug. Like, as soon as I hear that cough, I'm like, "Oh, no, here we go." So
Yes.
and I have to
Yeah.
say, we just had a big episode of this, and I was so thankful that I had your portable nebulizer on hand because
Oh,
Austin
they're
was
so
too scared for me to use the big one. It was like he was panicking, which was making his breathing even worse. And I was like, "Wait, I have this." And it was amazing. So like literally people look at the resources she has because it's a
Oh, I
game changer to
appreciate
be ready
that.
ahead of time.
That's so sweet, Casey. I'm sorry he went through it. I know you dealt with it a lot.
Whew. Well, so let's talk about croup because I feel like there's a
Yes,
lot of misinformation about it, about what
I
it is
agree.
and what it's not and who it impacts. So can you just give us like an overarching,
Yes,
like, what is croup?
sure. So, croup is the end result of some trigger in your upper airway. So, if a child has a virus, or they have allergies, or they might have other triggers, anything can cause inflammation in your upper airway. And then they get that inflammation. It sits in your upper airway, so the area around your vocal cords and trachea. That end condition is called croup. So, in other words, you might have a cold, right? Like maybe you have a cough or cold. It's kind of sitting in your chest a little bit, and then you also get that coughing sound, that barky seal-like cough that we call stridor. That is croup. But it's kind of the end result of whatever the cause is that's sitting in your airway. Does that make sense? So maybe you have
Yeah.
allergies to something and you're inhaling a bunch of dust or something, and that inflammation is sitting there. And then suddenly you get a barky seal-like cough. That's croup. That's the end result. It's a condition that happens in your airway as a result of a few different triggers.
Okay. That makes sense. And I guess my question is, so for my kids, it seems like that's the first thing I hear. So it's
Yeah.
that they're working to fight that whatever it might be off,
Yeah.
and that's where you start to hear that.
Yeah, and for some kids, they're a little more prone to it because of the anatomy of their upper airway. So they might have a more narrow area in the space around their vocal cords compared with other kids who could get the same viruses, and you would never hear that croupy sound. Does that make sense? Because
Mm,
what happens is, and this is totally nerding out, but basically, I know you like nerding out, so
I
that makes me
do. I love it.
feel okay. When you get inflammation in your upper airway, it's like a tube, right? So you got inflammation in it and it makes the space more narrow. And so if you have a narrow little tube and you're trying to breathe in and out, the sound you will get, it's the sound of turbulent airflow. So basically air has to push its way out of a more narrow tube. And that's that sound that you get, that croupy bark like cough.
Mm,
But other kids might have really big airways for whatever reason. And so it's just their anatomy that they could have a bunch of inflammation and they could still breathe in and out totally comfortably. So part of it is just genetics. Like some kids are prone to it. You often see it in families that they're prone to it.
mm.
And some kids, it might be they have an anatomic reason for it that's other than genetics. So, maybe they were premature, they were intubated, or they had some sort of swelling from something else in their history.
Gotcha. That makes sense. And is that
Yeah.
related to when kids like because past a certain age, it's like not expected to have croup, right?
Yeah, you're exactly right. So the ages that we typically see croup are are somewhere between 6 months and 5 years old. But really, the peak of when we see it is around 2 to 3 years old. So that's kind of
Oh,
our peak time. So if we see a child who's less than 6 months old who has that stridor sound, like that barky cough, or a kid who's like 7 or 8 years old who's still getting croup pretty regularly, that's usually a flag for us to have them evaluated a little further just to make sure that there is no other root cause for it and no other potential anatomic reason for it.
interesting. Okay.
Yeah.
So
Yeah.
that's that over 7, you said?
So it's usually 6 months to 5 years old. So anyone
6 months.
over
Okay.
5, yeah, like maybe we'll see a 6-year-old here and there. But if we see someone older than 5, we do usually look into it further. Yeah.
Interesting. And is there any, this is just my own curiosity because Aud had strep and she ended up, it started with the croupy cough and she's 7. And
Uh-huh.
the urgent care doctor made a comment that strep does not go with croup. Like he was like, that was 2 separate things. And I had never
Yeah.
heard that before. Is that
Yeah, that
fair?
might be right. Yeah.
Oh,
Strep is sort of like really sits in the back of your throat. But it should be above your airways, right? Like it's kind of really just sits in your throat and your mouth.
mm,
And so maybe she also had a virus or something else, like the
interesting.
coughing and cold. So in especially like in school age kids, when we look at kids with strep throat, they can present with fever and sore throat, but they can also sometimes present with stomach aches. But if we see a kid who has cough, cold, and congestion and a fever, we don't always think about strep usually for the first thing, or
Uh,
they may have something else going on in addition. Does that make sense? But yeah, we
yeah.
don't usually put the two together because croup is like
Interesting.
from your airway down, and strep would be like airway up. Does that make sense?
Interesting. Yeah,
Yeah.
totally. Oh,
Yeah.
that's helpful. Okay, with croup in general,
Yes.
can we touch on recurrent versus
Yes.
atypical? Is that the other one?
Yeah. Yeah. So recurrent croup is basically when we identify kids who are at higher risk for having it again and again. And the reason that's important, right, is you want to make sure that if a child has had croup a few times, that you, A, have an emergency action plan for them so that, like, if they get it in the middle of the night, which is always, when it happens, that you know exactly what to do for them, but that also you start to think about if they need more evaluation. So recurrent croup is technically more than 3 episodes a year.
Mm, wow.
Okay. Yeah. And a lot of kids get that, right? Like a lot of kids that you see, you're kind of like, oh, my kid's a croupy kid. They always get croup in the winter and that's it. And it's not a dangerous thing. It's just that we want to be a little bit at higher alert for knowing that we can make a plan for them. And also to say, if they're really the next season, let's say, still getting these episodes, or if they're doing it at an age where we wouldn't expect it, we might want to look into it a little bit further. And then we have
Interesting.
things that are, that are called like atypical croup, which is basically if you have a child who has croup and they don't respond to the initial treatment that we usually give. So, usually it's a dose of an oral steroid if you're in the emergency room. If that doesn't work, we sometimes have to do an inhaled racemic epinephrine treatment. And if they're not responding to that, or if they get better and then get worse like a week or two later, so they get it back again, or if they're just not responding in the way that we would expect, we sometimes call that atypical croup. Um,
Uh,
these are also kids who, like, maybe it's not a virus, but maybe, they don't have cold symptoms before they get the barky cough. Maybe it's more allergies or things like reflux or other things. So we kind of like to work it up a little bit differently.
that makes sense. That makes sense.
Yeah.
So what else could it be? Like what else mimics croup?
Yeah. So it's a good question. So like there are lots of allergies that can mimic it. So sometimes environmental allergies, dust, other kinds of triggers like smoke, anything that you breathe in that could potentially cause inflammation in your upper airway. So allergies is a common one. A lot of times reflux can kind of be a hidden source of causing, all the liquid or all the milk or all the food kind of comes up and sits at the top of the back of your throat, and that can kind of lead to sitting in the top of your vocal cords. And so
Hmm.
reflux can sometimes be one. More rarely, birth kind of anatomic things, like maybe you were born with some sort of vessel anomaly around your airway or something that was subtle that we might not see. And
Interesting.
sometimes asthma, but not as commonly. Yeah.
Okay. Very
Yeah.
interesting. Wow. Who knew?
Much you think about. And croup is kind of neat because like you were just saying with it's like the second you hear the cough, you know immediately what it is, you know? And it's
Yeah.
kind of pediatricians always say, like, it's kind of not fun. There's nothing fun about being sick, but like there are times when I'll walk down the hallway and I'll be like, oh my gosh, room 12. I hear their croup right now. Like, I love a
Yeah.
diagnosis where I could just be like, I hear it down the hallway and I can fix you.
Yeah. Oh, I love it. Thank you for being here. It was amazing. We will link everything in the episode notes too so that anybody can refer back to it. And we'll see you next time on More Than Milestones.